Welcome to Sweet Talk. This broadcast is brought to you by the Continuing Education Workforce Training Division of Idaho State University's College of Technology. This podcast is part of our continuing outreach efforts, and the format is conversational. We will be having conversations with businesses, professionals, entrepreneurs, community agencies, and, in all cases, difference makers. Now, let's get started with Sweet Talk.
Hello, my name is Raylynn Price. I'm the Health Programs Coordinator here at CEWT, Continuing Education Workforce Training, and I have with me here a special guest. We have Dr.Sandy with us here in our podcast studio. This is a 20-minute podcast, and so when our timer rings, we're done. So we'll just kind of start out by maybe telling us a little bit about what you do. You are a doctor, but what is your role?
Well, currently I'm a board-certified emergency medicine physician, so I'm the medical director of the emergency department at Portneuf. I'm also board-certified in EMS, in emergency medical services, and I serve as the EMS medical director for Bannock County and Power County, Fort Hall, several other agencies surrounding Southeast Idaho and the State of Idaho Bureau of Land Management program as well.
And he's
medical
our
director
EMT
for
medical
the EMT
director,
education
yes.
program
Yes.
here at ISU as well, and also serve as the chair of the Idaho EMS Physician Commission, which is the oversight body that regulates scope of practice for EMS personnel as well as medical direction requirements in the state.
Okay, that's great. So you are very involved in
Very
EMS.
involved. I like to say that I really do more EMS work than anything else. Okay. The ER pays the bills, but I actually spend more time doing EMS activities than I do actually working clinically.
Okay, well, that's good to know. Perfect. Well, so tell us how you've been very involved, obviously, in our emergency medicine conference, both last year and this year, in planning it, putting it together, and also as a presenter, which we've appreciated. Can you kind of maybe tell people a little bit about the conference and why it's important, why Portneuf maybe got involved, and why it's important for our community and surrounding areas in particular to have this conference held here?
Yeah, it's really important. EMS is ever changing. We always, the big mantra is, and the recognition is that EMS is the practice of medicine. It is a subspecialty of medicine. As I said, I'm board certified in that, and it's constantly changing and constantly evolving. And so getting people together within the region on an ongoing basis to provide update, to provide education, networking opportunities, opportunity for discussion and learning is really critical and vital for ensuring that we have good care provided to our citizens, but also keep the EMS clinician competent and fulfilled and really up to date on the medical care that they provide.
And the best practices.
And the adage of building systems of care within medicine is so important, whether it be a stroke system of care or a STEMI system of care, a trauma system of care, a sepsis system of care. Everything has become so modularized in the care that we provide, and it's on a continuum. It's from dispatch, it's from the dispatcher is able to recognize the severity of what's going on, getting the appropriate resources dispatched. It's the crews being able to recognize, hey, this is a STEMI or a stroke, and we need to go in the case of the STEMI, directly to the cath lab. We'll bypass the ER, go directly to the cath lab, thus saving time and improving patient outcome for sure.
And that fits right into that time-sensitive emergency.
For sure.
I guess the theme of the conference, but also a strong emphasis what we do here in Idaho in our emergency medical services. Can you talk about that for just a little bit? Time-sensitive emergencies and why it's such a big deal?
Yeah, it's interesting in Idaho where we were one of the last to come to the table with a formalized system of care, in particular for trauma. All the other states had well matured trauma systems that have been in place since the mid-'70s, early '80s, during the heyday of trauma system development. But Idaho was always pretty slow to come to the table. But the one thing that it allowed us to do was, when we did develop a trauma system, we actually built a three-pronged system. We built the trauma system, we built the STEMI system, and we built the stroke system, awesome. All at the same time. And other states that have very mature trauma systems are trying to put these STEMI and stroke systems on top of the trauma system and build, and they're just getting a lot of roadblocks and barriers. Okay. No offense to the surgeons. They don't like, STEMIs and strokes and talk about those, but the same paradigm of a trauma system of care we've been able to develop with that STEMI and stroke system. So
that's great. So have you seen improved outcomes in patient care because we have initiated this time-sensitive?
I think anytime you start talking about issues and items, you're going to see increased focus and you're going to see better outcomes. Have we been able to do a study and show, hey, since we have these trauma centers in place, we have better outcomes? That data is really not there yet, and we can't really point back to a good epidemiologic study that says, hey, but anecdotally, we know that improving the care provided at the scene of an accident, decreasing the delay of getting that patient from the scene into the trauma center, from the trauma center into the OR or ICU, we know that those anecdotally have better outcomes for those patients.
Time is everything.
And time is everything. Yeah.
As far as outcomes and what you're going to end up with in the end.
I think the biggest thing with the time-sensitive emergency system that we have seen is the activity of the smaller critical access and community hospitals. Idaho's always had 4 or 5 hospitals that have served as trauma centers, whether it was, Bannock and Portneuf, Ermac, St. Al's, Kootenai up north. Those have always been the standard for trauma centers within the state, and they all provide very high level of surgical trauma care. With the TSC system standing up, we're now seeing level 4 trauma centers in Arco, in Soda Springs, in Malad, which these hospitals have stood up their quality, have stood up their training and education of their providers and staff. And I really think that that's where you see some of the biggest increases in good care, is in these rural areas.
That's awesome. Oh, we've got a question out here.
Can you explain the different levels of, Portneuf is a level 2 trauma medical center. What is the difference in the different levels of?
That's a good question.
Yeah, so within each level, even within STEMI and stroke, there are various levels, but in trauma, a level 1 center, they do everything. They're typically attached to a academic center, a university. They do a lot of research, and they have a lot of redundancy in services provided. A level 2 center does pretty much the same thing as a level 1. They just don't have the university attachment and don't have the level of research and academic, quote unquote, involvement. But level 2 centers, you have trauma surgeons, you have backup trauma surgeons, you have neurosurgery, you have ortho, you have the full spectrum of subspecialty, whether it be plastics, oral maxillofacial, ENT, and then you move down a level 3 center. Typically, you have a surgeon, and that's basically the general requirement. You have an emergency department that provides trauma stabilization, but you have a surgeon who is able to respond and participate in care as needed. They typically don't have neurosurgeons. They may or may not have consistent orthopedic coverage. And then a level 4 center really is you have an emergency department and you don't have consistent surgical coverage. And those areas, as a level 4 center, you're really meant to stabilize patients. You assess, you stabilize. If they have critical injury or serious injuries, you transfer them on up into the level 2s or level 1 centers. In Idaho, we even have a level 5 center, and that's really meant for the clinics. You have the Chalice Clinic, for example, that is a federally funded clinic. They don't have, quote unquote, an emergency department, but they're so rural that they could participate in the trauma program because they would be a receiving center when they do see the patients. And then we see that on the STEMI side as well. STEMI, there's various levels, whether you have a cath lab and you can do what's called a percutaneous intervention or a cardiac cath to open the blockage, or whether you simply stabilize that patient. You may give a TPA clotbuster drug and then ship them to the PCI center. And then stroke is the same way. Stroke, it's an emergency department. You can identify a stroke with your CT scanner. You can give the clot-busting drug, and then you ship them into a center that will do what's called thrombectomy, where they actually go up into the artery and go into the brain with a wire and remove the clot mechanically. And
Amazing, actually,
yeah, some of those advancements are kind of crazy when you think about what they're doing.
Yeah,
So,
for sure. And the outcomes, the improved outcomes, everything is about improving that outcome for that patient.
yes,
Having the,
yes.
the best recovery possible.
Yep.
Right.
And what we see, and trauma, trauma is the leading cause of death in the younger populations. And we're finding that trauma is becoming a very common cause of death in the geriatric population as well, just from ground level falls.
Wow.
They fall, you break 4 or 5 ribs, you then go into you get respiratory issues, you fall, you get a bleed in your head. So trauma has always been that focus because trauma occurs, it's really from age 2 to age 45 it's still the leading cause of death. Well, that age group, that's when everyone is supposed to be working and being part of society and contributing to society.
Sure.
And if you have bad outcomes there, then you miss out on all the implications in society. As you get into strokes are more devastating and probably cost more money directly. But it's important that you do the best that you can, because it could be the difference between an individual having a stroke and ending up in a nursing facility for the rest of their life with
Sure.
full care versus actually being able to be home. And there's that cost associated with that, as well as the societal stressors of family and health and just everything in general. And then same thing with the STEMI, the heart attack, those critical 35 to 55, 60 years of age range when we really see a lot of these heart attacks has a great economic impact.
Sure.
So,
That's important to think about. You think about the health, but the economic is a whole another issue, isn't it?
Yeah.
So tell me, what emergency medicine trends do you kind of see coming in the next 5 years?
Yeah, it's interesting. We're really, I don't want to say we're at a crossroads. We were at a crossroads in 20 years ago when it came to EMS. In fact, the Institute of Medicine had a report, the crossroads of EMS in rural America in particular, and that report was 20 years ago. But I think some of the things we're seeing right now is there's going to be a huge distinction between EMS as a public safety discipline and a healthcare discipline. Okay. And why I say that is because of the advancement of mobile integrative healthcare, or in Idaho, what we call community health EMS. EMS across the country is starting to do more and more primary care. They're starting to do more injury prevention, health maintenance. They are, the federal government, CMS, just released grant money, announced it last week, for a huge number of agencies across the nation to do innovative programs, in particular with Medicare patients, but that include transport to non-emergency departments.
Interesting.
Okay, so you get a phone, call 911, you go to the house, you determine, they really don't need to go to the ER. So we're going to take you down to this urgent care. And you're going to be seen at this urgent care. Or we're just going to call your doctor, and your doctor will be aware of what's going on, and they will send out either a case management nurse or a clinical nurse to come out and do a home visit and address that. The whole approach is to shift really the healthcare dollars and keep patients out of the hospitals, treat them in their homes as much as you can, and then get them to the level of care that they need.
That's the most appropriate.
That's the most appropriate. You fall down, you get a lack on your arm or leg, you don't need the emergency department, unfortunately, right? You can go to a family physician, you can go to urgent care to have that taken care of. But for a lot of people, it's the transportation and such becomes an issue. So the ambulance is that mode of transportation. Yeah.
Very cool. Well, good. So talking about our emergency medicine conference, of course, we know that it's important, and there was definitely a huge purpose and drive to be able to bring this emergency medicine conference. How do you see that as far as why we're doing this and how it can benefit people? And maybe a little bit about the training and what.
I think the drive was that there was always a gap here within Southeast Idaho for a emergency medicine or even just a straight EMS conference. And everyone here, they were going to Sun Valley, they were going to Twin, they were going to Idaho Falls to conferences and such. And I think really as ISU is the healthcare university of the state, it made sense that ISU stands up a medical conference, specific for this population or with this focus of provider. And so I know Portneuf and Portneuf Air Rescue have been very excited to help be a part of that and sponsor that and participate in the conference as well. And I think bringing in, as we see, bringing Eric Bauer in this next year, as you start bringing more national names in, not that the conference is going to get better, but you're bringing guys in who, Eric, that's what he does. He
Right.
teaches.
He's an educator.
He's an
Sure.
educator. He teaches across the country. And so you bring these well-known educators in, and it just raises the level of your conference and the attractiveness of the conference.
So somebody attending our conference, what can they bring home with them? What are they going to learn?
Yeah. Well, hopefully there's anything and everything for everybody and anybody. Right? Between the cadaver lab. I mean, you could come to the conference just for the cadaver lab.
Sure.
And you would go home just hopefully very much excited and with an abundance of increased knowledge just from being able to see a cadaver, review anatomy on the cadaver, go through organ systems and such. Whether it's the simulation as well, being able to use the simulation trailer and go through scenarios that otherwise you're just doing.
There we go. There's our timer.
There you go.
We'll let you kind of finish up with that thought.
Yeah, but simulation adds a whole new game to practicing or preparing for calls.
Yeah,
So.
I know sometimes people get kind of scared by simulation and they think, oh, somebody's going to be judging me.
Yeah.
I'm going to be tested on what I know and maybe feel uncomfortable. But I know that our guys running the sim experience have said, no, this is a time just to come in. It's hands-on, it's learning, no judgment. There's a lot of things that you can.
And the best thing, the sim mannequin doesn't care.
This is true. This is true. It's a good place to practice.
It's
right?
a good place to practice. It's the only time your patient really isn't going to care. So
I hadn't thought about it that way, but that's a great way to look at it.
Yeah.
Very cool. Well, good. Well, thank you so much.
Yeah, no problem.
I do appreciate that. Remember, our emergency medicine conference is May 1st and 2nd here at Idaho State University. And we are excited to host it and we hope that everybody comes. It will be a great experience.
Yes.
Thank you.
Thank you.
Appreciate
Thank you.